One of the things that's very exciting for me is thinking about the way these technologies are getting adopted all around the world and listening to people that are talking about the needs in the different areas so that we can respond to them. So I'm going to show you several of the things that we've got kind of under the hood, things that we are thinking about bringing out in the future and some things that are in the pipeline. But first I want to talk a little bit about technology in general. So this is a graph that shows life expectancy in years, income per person along the bottom. And this is from 1916. And all of the little clusters of dots represent individual countries around the world, color-coded for the region that they're in. So Asia is color-coded in red, and you can see China and India are still the predominant nations in terms of population 100 years ago. You'll also notice that as the countries were getting wealthier, they were also getting healthier. There's a line that you can draw that sort of runs through the countries, and you can see that they're sort of generally falling on this line. You'll also notice that just 100 years ago, almost none of them were over 50 years in terms of average life expectancy. Now, if we run this forward, we start to see it's very interesting, and I find these graphs very mesmerizing as I'm watching history step forward, and you can see plagues, you can see world wars, you can see relative economic movement of one country versus another. But another thing that you'll notice is that they're all moving up, and they're normalized for economics. So it's the same dollars that they've been normalized to. And all of these countries are moving up in terms of life expectancy, but not all of them are getting enormously wealthier. And so we get close to the days where we are right now. And actually, you'll notice India kind of goes straight up for a while, and then it starts to do this great rapid increase in terms of economics. But we get up to close to 2016, and you've noticed that all of these countries have moved above 50-year life expectancy in the space of 100 years. You'll also notice that this line is considerably higher and it's flattened out. So that healthier getting wealthier, we kind of broke it in the last 100 years. And a lot of this is technologies that we're very familiar with as clinicians. They're vaccines, they're antibiotics, but they're also surgery. And a lot of the surgical technologies, because as our populations are getting older, we're unmasking the diseases of aging. So unfortunately, a lot of surgery is still looking like this around the world. And I say unfortunately because the incision itself serves no therapeutic purpose. It's really what we want to do on the inside that is what we're trying to do surgery for. And if we can get rid of these incisions and we can move to minimally invasive surgery, and I show laparoscopy on purpose because I believe that laparoscopy and robotic surgery work very, very well together. What we found in the 30-plus years since the introduction of laparoscopy is that minimally invasive surgery has penetrated fairly far into a lot of surgical areas. But it got limited as the surgeries got more and more complex. And as you've been hearing in a lot of the cases today, people are saying, yeah, well, my simpler procedures, but when I no problem doing laparoscopically, but when I move into something with a larger uterus or I've got a more complex dissection or a more complex reconstruction, this is where you start to move into robotics. But more and more operating rooms are starting to look like this. The Da Vinci is not the only surgical robot out there. There are, in fact, quite a few surgical robots out there. Now, most of them are in the orthopedic space. The Da Vinci is the main soft tissue robot, but we're also seeing catheter-based robots and that are doing vascular surgery. And in the sincerest form of flattery, category, we're also starting to see a whole series of other companies bringing out robots that work very similarly to the way the Da Vinci works. Mainly, they're doing that because the idea of providing patients minimally invasive surgery is a compelling one. And we want to be able to bring all of the capabilities of our hands inside the human body without the big incision, and instead moving to the small incision. So I'm going to now start showing you some of the things that we're playing around with. So this is a single port robot, where we go from multiple incisions now to a single incision. For a lot of the complex surgeries that we're talking about, this will probably require an additional port in order to do large lateral retraction. So you've got a 1+1. But for many of the exploratory surgeries, these are the kinds of things where you'll be able to just do it through a single incision in the belly button. But as we start to think about bringing that incision smaller and smaller and smaller, we have to say we're not actually doing everything that we need to do for the patient. And I'll illustrate this with the Kaplan-Meier that you guys are all very familiar with. It really matters what stage. I can have the fanciest robot in the world, but if we're catching the patient at stage 4, we're really not affecting the overall outcome. And so even though this is a lung cancer survival from a Chinese registry, they didn't even put stage 4 on here. And the average worldwide survival, at 5 years is 15%, because we aren't finding it at stage 1 and stage 2, where we know how to cure it, or at least prolong life surgically. We're finding it between stage 3 and stage 4. And so Intuitive Surgical thinks of itself as a medical technology company. We are making procedures for patients so that we can improve longevity as well. And one of the things that we are starting to look at is how do we bring that acuity down? How do we start finding these patients and treating them at earlier stages, especially in things like lung cancer? Now, there are technologies out there right now that are doing navigation, that allow you to do navigation bronchoscopy, but they have difficulties. And one of those difficulties is the lungs are very, very malleable. And so as you start to put a scope down through the airways and try to get to those distal airways, you distort the lung. And so if you're navigating with respect to external landmarks, you have moved where that tumor is with respect to the landmarks that you can measure from the outside. And so as we think about next stages of what is it that we can do in terms of improving the lives of patients, Intuitive Surgical has entered a joint venture with Fosun Pharma, a Chinese company, and we're working together to develop catheter-based robotics that we can measure the path as we're going through and no longer navigate from external landmarks, but navigate from knowing where we are in the bronchial tree. Now, this is totally an artist's conception of this. This does not exist. This is what we are looking at doing in the future as we start to be able to bring this together. However, we do have prototypes of these sorts of things working in the lab. But the idea behind this is thinking about not just how do we, a lot of people have said, oh, your robot is too big. Well, it's big so you can set up for the anatomy. If we reframe the problem and we start thinking about how are we just going to travel to where the disease is and be able to affect that change and be able to do something surgically useful at the tip, we start to take smaller and smaller footprint in the suite. In addition, you saw Firefly with ICG, which is frankly a kind of a dumb dye. It only goes where the physiology of the blood flow takes it. And so while we can look at watersheds, while we can look at perfusion in bowel, while we can do sentinel node, the dye will only go where the body is transporting it. It doesn't attach onto anything. So here in the endometriosis talks, endometriosis is near and dear to my heart. I did a lot of research in that area, and I've been searching for a molecule that will bind to endometriosis. I'm not there yet, but there are clinicians around or researchers around the world who have found molecules that will bind to ovarian cancer. So this is a folate receptor, so not every ovarian cancer will express this, but for a folate receptor expressing ovarian cancer, which is a majority of them, a surgically uncurable disease because you just simply can't find them all, becomes starry night. And if there's still glow inside the body, there's still cancer inside the body. And as we start to look at a lot of these tumor-specific binding, we can take the sorts of work that we're doing with the Firefly and we can turn it into a real cancer-finding tool. And so even if we haven't found it as early as we could, we are still able to, in some ways, downstage it by being able to find all of the parts of it. So in addition, this is you can see the sentinel lymph node work down here, but what ought to thrill everybody is the ureteral agent that you see in the top up there. So this is ICG, these are both ICG down here, and this is an experimental ureteral agent which is excreted renally and can light up the path of the ureter. Again, I'm showing you lots of things that aren't available today, but they are in development, and we're through toxicology studies on these sorts of things, and we're just trying to figure out, we're not a drug company, so how do these kinds of things get out into the market? Oh yes, I like this little video down here because this guy was doing a study looking at common bile duct injuries, and he kept finding aberrant ducts on the cystic duct when he was doing his, he got a much higher incidence of them than he'd ever really suspected he had. And he figured he was getting away with it because he was just clipping. We're also playing around with integrating other forms of imaging. These are all picture-in-picture right now, but this is there's a drop-in T probe for an ultrasound. And we've been playing around in our imaging lab with ways in which you can display this in real time in the correct orientation along with the organ. And on the right-hand side, these are confocal microscopy probes that with different kinds of staining agents, you can look at vasculature in the upper right, and in the lower right, nerves. Unfortunately, that's with Crescel Violet, which you're not really going to leave in a patient, but we've been looking at different ways in which we can try to dye the myelin sheath so that we can look at them with confocal microscopy. So no promises on the nerves yet, because we haven't yet found something that integrates into the myelin that you would be willing to put in a patient. We've also, in our imaging labs, started to look at integrating 3D, a lot of the preoperative imaging that you get. And so this was a auto-segmentation of the vasculature for a kidney, and it's being overlaid over a kidney, that same kidney during surgery. You'll notice a problem with it right away, which is all of the patients are imaged supine and non-insufflated and with no Trendelenburg. And we insufflate them, we dissect, and then we try to take an image that was how they were structured preoperatively and fuse it onto the structure underneath. And so this was looking for the vessel that could be taken to do a partial nephrectomy. And there was considerable confusion because getting those to overlay very well was difficult. So this is an area of research that we're working with a lot of different university groups around the world on essentially deformable registration. which gets us to a lot of the data analysis work that we're doing. How do we think about AI and applications of AI into this form of robotics? So the kind of AI that you may be familiar with if you followed, this is Watson. And IBM created this natural language processing, essentially expert system. It's very good at responding to a natural language query. It can search through its enormous database of basic information, or actually very advanced information, and be able to serve that up in response. So it's like having the perfect resident that you can ask and they will answer that question right away. So this is an expert system type of AI. Another form of AI is what, if you've been hearing about machine learning or deep learning, is a pattern recognition form. So these two images came from experiments that Google was doing with what are essentially where you take a set of data, and unlike the Watson, where you know the answers to all the questions and it's a question sorter, you don't know what you're looking for. And you dump all of your data into this algorithm and you say, match the patterns for me. Tell me what patterns are showing up over and over and over again. And so this was their sort of their face meme or the face neuron in the deep neural network that was, and something they never expected, which was a cat face. And it came out of Google dumping all of the YouTube videos into this algorithm. And it came back and it said, cats seem to be very important on the internet. And it had found the cat video independently while only being asked to look for patterns. And so this was, and what is medicine but pattern matching? We start to we learn what is healthy, and we learn what is pathological, and we learn to tell the difference between them. And with these kinds of learning algorithms, we can start having these algorithms help us differentiate. So my husband's a Go player, so we watched stone for stone every move of Lee Sedol matched against AlphaGo. This is yet another kind of AI. So what they did with, if you're not that familiar with Go, it's very much of a sharing game, and it's a territorial influence type of game. It's been very, very difficult for AI to be able to make any kind of a dent in really being able to play Go. What they did is they took all of these master games, and similar to Watson, they put all of the sort of, this is the perfect game, into the algorithms. And so they learned essentially to be able to predict what people would be able to do what people would do for their next stone. It then made it play itself. And it played itself for thousands and thousands and thousands of games. And in game 2, move 37, a stone that just rocked the Go world was placed by AlphaGo. This game's been played continuously for more than 2,500 years, and no one had ever seen this strategy that was represented by that stone that got put down. It's still being analyzed by high-level Go players. It had developed a new strategy by playing itself. This is the sort of area where we start to think about, now Go is very constrained, but when we start to think about application of machine learning to medicine, we start to think about it developing the kinds of rules that we develop internally in order to help us understand the body, how to figure our way through a diagnostic tree. And I start to think about these AI technologies as something that, along with the advanced minimally invasive surgery, some of the things we're doing in early diagnostics, these fluorescence imaging, as another one of these cornerstones that as we digitize surgery, we get to start bringing them in, and we get to start improving and supporting the clinical decision-making. People ask, when is the robot going to be doing the surgery? There's a lot of navigational help, but the decision trees are still so far beyond what we can do with AI that I don't think we're taking the surgeon out of the loop anytime soon. But these are very exciting areas where we start to be able to bring some of these technologies in and make the job of the surgeon easier and more effective and do a better job for our patients. And so with that, I will throw it open to questions.